So thank you very much, Khalid. Thank you everyone for being here. It's a pleasure. I don't know in person. I hope to do that very soon in person in Dubai. Let me just share my slides. I think you see my slides, right?
Yes, doctor.
Okay, so thank you very much again. And in the next half an hour, more or less, I will try to speak about the treatment of these infants, so those with the more severe BPD. And I'm afraid that some of the things that I will tell you will be more or less overlapping with those that have been treated by beautiful speakers before me, like Dr. Banhari or Dr. Bancalari. Anyway, I'll try my best. And I also will give you a little bit of our local cookbook. I mean, what we do actually in Paris for these babies. So first of all, let me see. I want you to remember that the situation is very much complex. BPD is supposed to be a dichotomous outcome, but this is not true. We decided to code BPD at 36 weeks, but this is an artifact somehow. And in fact, as you may see here, the International Neonatal Consortium, where Eduardo and I also participated, actually recognized that the BPD is an evolving process, and it's something that is starting from the birth, even before the birth, and then evolves, and then even beyond 36 weeks, even beyond 40 weeks, you can have signs, as well as you can have signs very early before reaching the 36 weeks time point. So this full time point is now called CPIP, meaning chronic pulmonary insufficiency prematurity, as you may see from this consensus statement from INC. And that's extremely important because when we talk about severe BPD, we have to talk also about those that are evolving towards a severe BPD. So those that are actually having a CPIP that is evolving towards a more severe clinical picture. This also means that our interventions, as you may see here with all these arrows, may take place at different time points. They may be pretty early, or they may be anyway before the 36 weeks or later. So first of all, let's have a look at what you don't have to do to avoid severe BPD. So what you don't have to do is, first of all, intubate the baby in the delivery room. I know this is a little bit easy and may seem silly, but that's the reality. This is the meta-analysis from George Smalls in 2013. As you may see clearly that the CPAP, well delivered in the delivery room, is going to reduce BPD and mortality with a number needed to treat of 1/25. I will get back to that later. But I can tell you that it's really the reality, and it's really the main stem for the prevention of BPD, especially the old BPD, as Eduardo said 1 hour ago. We started to avoid neonatal intubation in the delivery room in Italy, like in 1997, 1998, so well before that. And I can tell you that this is true. The trend is absolutely correct, and that's the first main stem to do. Then there is another point. Even though you avoid intubation and you have a very well delivered CPAP with the right interface and with the right type of CPAP, and we could talk about that for quite a long time, sometimes you need surfactant. And what is really important, as you may see here from this Cochrane meta-analysis, is that surfactant should be given very early in order to reduce mortality and BPD. And very early means, as you may see, in the first 3 hours of life. So 3 hours may seem a long time, but actually it's not. 3 hours is very quick period, and you have to do many, many things in 3 hours. And you also have to decide if you can stay and play in CPAP, or you gotta go for surfactant administration. Doesn't matter if you use Insure, Lisa, or whatever you wanna use it. So that's a real picture from our NICU, and this is our local cookbook. So every time you see a blue slide, it's just because this is not gospel, it's just how do we do things in Paris. So basically we start variable flow CPAP with nasal mask from the delivery room at 6 centimeters of water. The NIC is very close to the delivery suit. And then we have a protocol that is called Golden Hour Protocol. And in the first hour of life, these babies are only submitted to a UVC placement, starting TPN and caffeine, the first bolus of caffeine. And then we do our lung ultrasound score to decide if we can stay in plain CPAP or if we gotta go for surfactant administration with a threshold of lung ultrasound score of 8. And then we get surfactant with Insure, and then again, non-invasive support with a minimum 8 centimeters of water of minimum weight pressure. So that's the basic for everyone. So now let's have a look at what you may want to add in order to prevent or treat severe BPD. And I say prevent or treat depending on the time point when you start these additional interventions. It may be a sort of a prophylaxis if you are before 36 weeks in that time window of early chronic pulmonary insufficiency and prematurity, or it can be a treatment if this is later on. We also have to admit that we don't have so many treatments. Unfortunately, we are a little bit disarmed against BPD still, hopefully not for so long. I will tell you something about that by the end of my presentation. So here you see a small list of what may be the pharmacological weapon against severe BPD. Inositol is in gray because this has been tried up to a phase 2 trial. May seem interesting, but we absolutely don't have any phase 3 trial, so we cannot use it. And IGF-1, the insulin growth factor number 1, which is very much promising, is now under advanced investigation with a very large multi-center international phase 3 randomized controlled trial. I'm sure you have heard of it, and I will tell you something about it later on. So let's start from the non-invasive ventilatory policy. That's very much the main stem of this part. Exactly the same way, avoiding intubation in the delivery room and giving the right CPAP and giving surfactant early was the cornerstone of this side of the history. So this is our protocol. This is our local cookbook in Paris, and this is what we do for these babies. So as I told you, when a baby got its insure, after the insure is placed under CPAP or biphasic CPAP anyway, with a minimum weight pressure of at least 8 centimeters of water. And this is because that a little bit higher minimum weight pressure level is demonstrated to reduce the extubation failure and improve oxygenation and surfactant diffusion. And I want you also to remember the beautiful trial published by Eduardo's group in Journal of Pediatrics in 2015, if I can recall correctly. But then sometimes something went wrong. It may happen, and a baby who was on CPAP at 8 centimeters of water cannot stay in CPAP because you see that it's deteriorating somehow during his trip. And I'm talking especially about the extremely low birth weight infants, those below 30 weeks or below 28 weeks or more or less. So you may face two situations. You may face a situation with an increasing work of breathing, so a Silverman score that is going higher and higher, and an increasing oxygen requirement to achieve a good saturation between 90 and 95%. So in this case, we are here in the blue line. What we do is to shift the baby from a CPAP to a real non-invasive ventilation that we usually provide with NEVA in order to have a perfect synchronization, a discharge, work of breathing, and also a good comfort from the baby. If we do not have enough NEVA machines available, because unfortunately we have 40 beds and we do not have 40 NEVA machines, we try to do the non-invasive positive pressure ventilation, but synchronized with flow sensor or a pressure sensor. Usually this is something that is nicely working. Sometimes if this is not working, our rescue therapy in this case, just because we really do not want to intubate again these babies, it's nasal high frequency or scheduled ventilation with a physiological approach with an increase in the minimum pressure under NHFOV, which is exactly the same alveolar recruitment approach that we are used to use and is very much known in endotracheal, in invasive HFOV, as the Anton van Gram group described it for the first time almost 20 years ago in the Blue Journal. Then there is another situation, because you may face a baby here that is deteriorating in an even worse way, and it not only has an increasing work of breathing or oxygen requirement, but also respiratory acidosis with increasing hypercarbia. Well, in that case, we go directly for an NHFOV because of the high power of an NHFOV to wash out CO2, both from the upper airway dead space and eventually also from the alveolar tissue. Usually this phase is gonna last a couple of days, 2, 3, 4 days, and you should have an answer. And then, according to the baby situation, you can go back directly to the CPAP, more or less to the same pressure level, or you will need to continue with non-invasive ventilation, and so to go to the other arm here. I have to admit that it's complex and it requires the knowledge of many ventilatory techniques, but especially requires a good nursing. Nursing is extremely important in these babies, and especially when one of these babies is under this unstable situation. Those babies are also monitored over time very closely, are considered to be a very high risk. And we do a sort of a multimodal non-invasive monitoring with the lung ultrasound, which is done more or less every 3-4 days, transcutaneous blood gas, and some scores for the comfort evaluation and above the saturation and perfusion index. So those are some pictures of the real life of babies that were under NAVA non-invasive ventilation, as you may see here. And here on the right, you can see a video. One of these babies that was actually before being placed on NAVA was under 50% of oxygen to saturate 90% with a pretty bad work breathing. And then you can see him very quiet and nicely placed in the mother's arm without any problem, and with an oxygen more or less in room air without any big deal. So basically, the principle of NEVA is that you are there to achieve a sort of a compromise, and so to avoid the high workup breathing that is characterized by rapid shallow breathing and a high peak of electrical diaphragmatic activity, which are the electrical counterpart of this workup breathing and a high Silverman score. Or from the other side, you want to avoid a too much higher mean airway pressure, and so a trend to a flat electrical activity of the diaphragm, which means overcompensation. So by monitoring the electrical activity of the diaphragm, you can actually see what is the best compromise, which is achieved with very variable breathing pattern at the electrical activity of the diaphragm, a nice PaCO2, and a pretty low Silverman score. And this is usually achieved with significantly lower peak pressures compared to the conventional non-invasive ventilation, and also with usually a lower FiO2 compared to the, let's say, conventional non-invasive ventilation. So this is an example of some electrical activity of the diaphragm tracing from the very first work published by Jennifer Beck in Montreal at that time with the NAVA prototype. I want you to try to guess which one of these babies is actually sick and what are conversely those that are not sick. So I can tell you that those are all preterm babies, but none of them was actually very sick. Surely here you can see a neural apnea, central apnea. You see the tracing is flat. Here you can see a sick, a very big inspiratory effort. But basically, all these babies were completely normal. So this means that their breathing pattern was extremely regular, extremely different from one from the other, even erratic, if I can say so. And this justifies why it's so hard to synchronize non-invasive ventilation in an extremely low birth weight infants if you don't have NEVA technology. So that's a lot of data about NEVA that I'm not going to mention here today, but just wanted to tell you that according to our experience, even when you have an established severe BPD and you got a viral respiratory infection like flu or like RSV bronchiolitis, NEVA is able to improve the situation. So this was a controlled study that we did a few years ago in Italy. And you see these babies with bronchopulmonary dysplasia recovering from RDS induced by bronchiolitis. So mechanically speaking, that's the worst situation of ever. It's a nightmare because we have a mixed pattern. This is restrictive and also obstructive. Well, then these babies randomized to a pressure support ventilation or NEVA ventilation are showing all the better parameters in the NEVA group. For example, you see the comfort in terms of heart rate and pressures and the oxygenation, and no surprise, like any other NEVA studies, a lower peak pressure to achieve the same ventilation. And what is more important, the comfort was better in the NEVA group, and the duration of mechanical ventilation was shorter in the NEVA group. But there is one study I really want to show you because it's one of the more recent, and it's also one of the funnest I ever remember. So these guys, they use NEVA non-invasively in these babies with evolving BPD, and they place a very highly sensitive microphone in the incubators. And then they place another one in the baby's chamber, okay? And they did the comparison with babies under classical non-invasive positive pressure ventilation. So there is no surprise in knowing that babies with NEVA have a lower peak inspiratory pressure or FiO2 or CO2 or something. What is really funny, and it's really interesting, is that according to the microphone recording, babies under NEVA had significantly lower movements and significantly need to have the caretaker entering into the chamber or opening the incubator. So basically, they had less events, they were more comfortable, and the nurses had less need to take care of them. So clearly, this is not going to reduce severe BPD, but it's also something that we have to remember on top of the advantages of this technique. So now, how we can recognize that BPD is going to become severe, or even better, a CPIP, a chronic pulmonary insufficiency prematurity, is going towards a severe BPD. So one of the tools that we have right now is lung ultrasound. So this has just been published from my group in the Blue Journal. And you see, this is the lung ultrasound score in extremely low birth weight infants that are going to develop BPD here on the top, and those that are not going to develop BPD. So you can see that at any time point from day 0 up to 36 weeks, this was a very longitudinal study, the lung ultrasound score is always lower in babies not developing BPD, which means that they have a better lung aeration, and they have a greater lung volume. And particularly around 1 week and 2 weeks of age, there is a peak in lung ultrasound score that is observed. And no surprise, something like that has been reported also in other studies from Spain, namely, and also very recently from Italy. There is a multi-center study from Raimondi group and others who got published in Pediatrics. So these are very much consistent data. And here I can give you some example of one of these babies, just spotted 14 days of postnatal age with a very high lung ultrasound score and a high oxygen requirement. And here you see the picture, a very bad consolidation. This is just one picture, but I can show you it was more or less the same all around the chest from both sides. So this baby had a 15 on lung ultrasound score, 12 of oxygenation index, was a little bit on respiratory acidosis, as you may see here, and he even had a bit of pulmonary hypertension that started to be evident at that point in time. And I want you to recall also beautiful data published by Stephen Abban a few years ago, demonstrated that if these babies have, let's say, an onset of pulmonary hypertension between the first and the second week of life, that's unfortunately a significant risk factor for severe BPD later on. So facing one of these clinical pictures, you may decide to intubate or not. We do not want to intubate these babies, and so we use non-invasive ventilation, as I told you, but we also use nebulized iloprost, which is a potent pulmonary vasodilator, very much suitable and easy to use, much more than nitric oxide in non-invasive ventilation, which is very much effective in this case. As you may see here, we published our experience a few years ago. And you can clearly see the improvement in infant heart rate and respiratory rate starting NAVA, non-invasive ventilation, and iloprost later on. But especially you can see here the improvement in oxygenation on the left side of the cartoon, and the hemodynamic improvement in terms of the ratio between pulmonary and systemic pressure on the right side of the cartoon, thanks to nebulized iloprost during NEVA or during NHFOV anyway. So it's not just about that, because clearly it's really multifactorial, but I want to show you the data from my NICU before we started all this job. So 2012, before I was appointed there in Paris, with the data that we have right now. So babies below 32 weeks gestation, according to the classical NACHD BPD definition issued by Eduardo and Alan Job, now have a rate of BPD of more or less 6%. And we had a more than 15% in 2012. And no surprise, although these numbers are a little bit, well, are higher, surely when you just look at the babies below 28 weeks, still there is a very significant trend. So let's talk about the drugs. Basically, we have 3 drugs to remember here after the ventilatory policy. We have the vitamin A, caffeine, and the CPAP, if I can call it as a drug. So if you look at the number needed to treat, you will see that the vitamin A and the caffeine seem to be much more effective than the elective CPAP. But well, you have to recognize that CPAP is anyway unavoidable, also because these babies need a little bit of support to reducing the work of breathing, and because of the effect of CPAP on apneas of prematurity. And I want you to have a look at this number needed to treat with a different point of view. And it's very nice to see this paper recently published by Jensen and Barbara Schmidt and co-worker, where you can see the evolution of number needed to treat according to the incidence of that particular outcome in a particular setting, which is very much important. For example, you see here, number needed to treat for vitamin A was supposed to be 13, okay, at the level of the meta-analysis or the trial that first described this, this benefit. But if you go down with the advent of BPD to more or less 20 or 17%, okay, you see that the number needed to treat will be much higher. Okay, so this is something you have to remember in order to decide if you want to use that particular approach in your NICU or not. We personally use both caffeine and vitamin A, but it's also possible, for example, that the effect of vitamin A was just tiny in our low BPD incidence setting. I'll tell you something about that later on. So let's have a look at the Bpd physiopathology to understand how these different drugs may work. Unfortunately, Bpd is very much multifactorial and multifaceted. For example, you may see that there is a surfactant injury, okay, because of the abnormal postnatal lung development and because of the inflammation given by oxygen, ventilation, and infections, and other, unfortunately, many other triggers that are coming from postnatally. Ventilation is also inducing an inhibition or a maldevelopment of vascularization that may in its turn involve a metabolic alteration locally. Vitamin A can be somehow useful to revert this, let's say, wrong alveolarization, trying to promote a good alveolarization. CPAP and caffeine can somehow promote a good let's say, lung volume opening, avoiding the use of invasive ventilation. And especially, we have to remember that when we look at the alveolarization, when we look more in general at the lung development, we have to remember that there is a very first stage that is depending on the growth factor from the mesoderma. And then there is the last stage, much more on the alveolar side, that is actually depending on TTF1 or NKX1 gene. So this gene is a nomeo gene that is very much important for the alveolarization, and you know better than me that its depletion or anyway its deficiency or mutation are very often not compatible with life. But what is very much interesting is that that particular gene is controlled in its transduction by retinoic acid, so by vitamin A. So this is why vitamin A is important for the alveolarization, and it's so far, unfortunately, the only drug able to do something in this very much important biological process. And no surprise, if you look at the data, this is coming from Spears in American Journal of Clinical Nutrition some years ago, but it's still very much interesting. Those very low birth weight babies with a retinol concentration in plasma less than the given level have an odds ratio to develop bronchopulmonary dysplasia extremely higher, 3.5. So this means 350 times higher than babies with a good plasmatic retinal concentration. And this is exactly why some studies in the past have examined the use of vitamin A. I recognize this is a pretty old meta-analysis, but this is what we have. You see the diamond is on the left. So there is a significant, although small, reduction of BPD with vitamin A. We are more or less around 10, 15% in terms of reduction of mortality and or chronic lung disease and or just the chronic lung disease, as you may see here. Some more recent meta-analyses have been released, as you may see here. There's a couple of studies more, but everything comes to the same conclusion. You see again, the diamond is on the left for BPD. Well, I don't know how much value we should give to the NICU stay, which is such a, you know, multi-faceted and flu outcome, but for BPD, the data are very much consistent. So some may be worried about the use of vitamin A intramuscularly. Personally, I'm not, and we use it because I suppose that the damage done by an intramuscular injection is much less than the damage of developing severe BPD. And anyway, we use intramuscular injection with EMLA to reduce the baby, and sucrose clearly to reduce the baby's pain. But in order to avoid even this small side effect, there are a couple of trials ongoing around the world. This is the VITA trial in the UK, which is randomizing babies to receive high dose of oral vitamin A, as you may see here. This is still ongoing, and we hope to see we hope to see the results very soon. And then there is another one you probably guys are more aware than me, to which Jane Pillow contributed, and this is also ongoing with more or less the same design. So basically what we do here, well, we give vitamin A, 15,000 units, one shot per week, every single week, in babies below 28 weeks of age, if they're still oxygen dependent, or they are intubated, or they are a very high risk score, very high BPD risk at the third day of life, which is exactly, which represent exactly the same criteria used in the meta-analysis demonstrating a certain benefit of vitamin A for BPD. So let's see about caffeine. So caffeine is probably the oldest drug in this context. I want you to remember the wonderful CAP trial published by Barbara Schmidt in New England Journal of Medicine 2006. That trial was not originally designed for BPD, but as you may see here, BPD was extremely and significantly reduced in the arm receiving caffeine as compared to placebo. So this was maybe a little bit of surprise, but it's very much useful. Anyway, we should have given somehow caffeine for the prevention and treatment of apneas of prematurity. So we have one more important reason, and this is why we give caffeine from the first hours of life, as I told you. This is really the first thing that babies receive in the first hour of life together with EPN, up to 36 weeks gestation. But why we do so? Because time matters. Time matters, and so we can argue that the earlier caffeine is administered, and well, the better will be its effect. And in fact, one of the reasons why caffeine may be working in that is that, as we know, caffeine has a significant diuretic effect. So as you may see here from these curves in the CAP trial, babies receiving caffeine clearly had a mean weight change more important compared to placebo, meaning that they lost weight more quickly in the first week of life compared to the placebo babies, and then they still had a lower weight compared to the placebo arm. So this is why the time matters, and this is why we have to start caffeine as soon as possible. There are a few meta-analyses that have been published later on. This is one from Korea, only taking into consideration retrospective studies, so not RCTs. But again, all the data come to the same conclusion. You see the diamond is on the left, so this is in favor of reduction of BPD and or BPD and mortality as a composite outcome for babies receiving BPD, from babies receiving caffeine, as I told you. And then there are also other effects, other positive effects that have been shown by this beautiful work of Peter Davis. And again, you see the diamond is always on the left, also for disabilities and for cognitive delay and even PDA, surgical ligation, and so on. So really no reason not to use caffeine for these babies. But if you want to have more insights in terms of pathobiology, here you have an example of an animal model when the lung has been injured with hyperoxia, and you clearly can see the effect of caffeine compared to animals receiving placebo or receiving saline as placebo. But this is just an example. There are many studies of this type. So what we do in Paris for that, we give a 20 milligram per kilo bolus of caffeine in the very first hour of life, as I told you. And then we continue 5 milligram per kilo up to 36 weeks post-conception age. According to the apnea, we may want to increase the daily dose to 7.5 or 10 according to the situation, and is weekly adjusted to the weight gain. If the baby is not receiving any insure because he or she has a very severe respiratory disease, so is getting a longer ventilation, we also do a 10 milligram per kilo, a small bolus pre-extubation. From time to time, but it's very seldom, we check the caffeine serum level, and we had a look at some normative data for those that have or not have received extra boluses that you may find here in this publication that I show you in this slide. What about steroids? So the great hope would have been the nebulized steroids, because you know better than me that unfortunately IV steroids to somehow treat or prevent evolving severe BPD are not free from side effects. Well, unfortunately, I believe that we can say the last word about nebulized steroids. There is such a meta-analysis that you may see here demonstrating no effect of budesonide, but also you may want to know that this absence of effect is probably due to a lot of reasons, notably the lung deposition, which is extremely variable, low, and dramatically affected by the lung injury, by the type of ventilation, and also by the type of nebulization, as you may see in this animal model. And again, there are many other studies. I just mentioned this one because it's from France. You will forgive me. And after all that, we also have to look at the Neurosis Trial, which has been really the very last trial on nebulized budesonide. And here again, unfortunately, no effect, no benefits in terms of BPD. And even if you look at the component of primary outcome subdivided between them, and so particularly you look at survival free from bronchopulmonary dysplasia, there's a pretty bad surprise, because that survival is going to be lower, significantly lower in the budesonide group compared to placebo. I have no particular explanation for that, but surely this is not something that is warming me up to use every day in my activity, nebulized budesonide. We could have talked about the intratracheal budesonide admixed with surfactant. Not having much time for that, but this is surely something interesting, because by this way, at least, we are sure that budesonide is getting there exactly where we want it, so in the alveoli. And since budesonide is sort of a sterolic molecule, it can be very much liposoluble into surfactant. You know better than me that there are studies done in Taiwan by Dr. Ye and co-workers. There is a hard rationale behind the use of budesonide in this setting, but I also want you to remember that in the Taiwanese studies, the starting point of BPD incidence was 50–60%. So it's extremely higher BPD incidence, probably induced by a lot of inflammation due to mechanical ventilation. We cannot actually extrapolate these data and think that there is exactly the same effect in a NICU or in a setting when there is a lot of non-invasive ventilation and so a lot of less inflammation in these babies. So still IV late postnatal steroids are there, and sometimes, although very rarely, may be used. It happens very rarely, but what we know is that they can be used only after 7 or 14 days of life. This is nothing new. You can see this meta-analysis again demonstrating the reduction of BPD when you use them. But again, if you look at the date of these studies, no surprise, these are very much enrolling. These were very much enrolling babies different from what we have right now. Not because they didn't have any NEVA, but also because they had much less prenatal steroids, much less non-invasive ventilation as a rule, and a different concept of neonatal care in general. And this is exactly why, to give you our local cookbook in Paris, by using our protocol on non-invasive ventilation, I can tell you that the need for intravenous steroids almost disappeared. It happens to use intravenous steroid to extubate somebody who has been stuck in on a ventilator more or less once or twice per year in my unit. So the big question for you is, do we go for low dose dexamethasone, or do we go for hydrocortisone when we really have to use intravenous steroids? So this looks like, you know, a little bit US versus Europe. Low dose dexamethasone is something very much American, like hydrocortisone seems very much EU based. I have no suggestion, I have no clue about that. I personally believe that both of them are safe. So also dexamethasone can be safe if it's very low dose, but you have to pay attention to the higher dose, because as you may see here from this beautiful paper from Arialde, clearly the higher dose of dexamethasone are associated to a lot of side effects that you know better than me, while we know, because of all the studies done, especially in the Netherlands, that hydrocortisone is very much safe. And you may see here from this one from 2015, absolutely no risk in terms of disabilities or cognitive delay or other neurological abnormalities in babies who have received hydrocortisone. You probably know better than me that there are 2 trials that actually showed the use of hydrocortisone very early, even for extubation, in the first 72 hours of life. One of them is the Premiloc study has been done in Paris, not in my unit, but in France anyway, demonstrating an effect, a positive effect of very early hydrocortisone. The other one is the STOP Bpd trial driven by Anton van Kam in the Netherlands and in Belgium, who did not demonstrate any benefit. So again, here, I want you to tell you to pay very much attention. The babies in the Pramiloc trial, the one that demonstrated the benefit of hydrocortisone, were in more than 50% of cases stuck in on a ventilator on 72 hours of life. The babies in the non-BPD trial in Belgium and in the Netherlands were mostly under aggressive non-invasive ventilation. So again, that's a basic confounder. This is really a game changer. If you do an aggressive non-invasive ventilatory policy, your need to use steroids will be significantly reduced, and so the effect of these steroids may have. So this is the schedule of hydrocortisone that we rarely use. It's basically adapted from the Rademacher study protocol, nothing really new. And then to conclude, as I told you, there is the IGF one, the insulin growth factor 1, which is, let's say, giving us a lot of hope, not only because it's on a phase 3 multi-center international randomized control trial, but also because in my mind, IGF-1 seems to be right now the only drug pro something, so pro alveolarization, so helping in developing normally a biological process. It's more or less what the vitamin A was supposed to do, but vitamin A does not do that very well. So far, we only have done something anti-BPD, like giving steroids to be anti-inflammatory. So using non-invasive ventilation to be anti-inflammatory somehow. And IGF-1 has the potential, at least theoretically, to promote a good alveolarization. So the trial is called Footprint, is now ongoing. We're participating in that, as many of you, I think, and we hope for the best for the future, although this is not free from complications, and especially from a logistical and practical point of view, but we hope for the best and we will see. So thank you very much for having listening to me, and I'm very happy to take all your questions.
Dr. Khalid, your mic is mute.
Sorry. Thank you, De Luca, for this really nice, precise lecture about the BPD. And there is one question asking about what you do for those who don't meet your lung ultrasound score.
I cannot hear.
Your voice is very low, doctor.
I don't hear very well. I'm sorry. I didn't hear the question. The volume was very low. Can you repeat, or shall I read the questions on the chat?
Who is asking the question?
Dr. Khalid, your voice is not coming. So I think there is some audio problem from your end. So if Dr. Rajiv or Dr. Rajesh can take up the question, someone.
Okay, I'll take, sorry, Dr. Khalid is there now. Is your mic on, Dr. Khalid?
Yeah, but there is some problem. We cannot hear, doctor.
Okay.
Yeah, so Dr. Rajesh, if you can take the question, what Dr. Khalid was asking.
No, I didn't hear the question. That's the problem. Okay, so I think there is a question, what would you do for those who do not meet your LUS score?
You mean at the birth or later on? So babies that at the birth have a lung ultrasound score lower than 8, they stay on CPAP, they don't get surfactant. They stay on CPAP and they go on very easily.
Okay.
Taufik,
Yes, doctor.
can you make me visible? Taufik, can you hear me?
Yeah.
Taufik?
Okay. Doctor. Just start your video.
Okay. Daniel, can you hear me?
Yeah, you're
Yeah,
recording.
I can hear you.
Yeah, Daniel, I wanted to ask you, what was your ventilatory strategy in babies with severe BPD? I wanted to ask you your ventilatory strategy.
But you mean when the BPD is already established and
Yeah.
but basically the ventilatory strategy is what I showed you in the slides. We use all this combination on an invasive ventilatory strategy. So we according to the physiopathological pattern, according to hypercarbia or hypoxia, we use NEVA non-invasively, or we use the non-invasive high frequency oscillator ventilation. In the rare cases that got intubated, but again, this is extremely rare, we are a more HFO NICU, so we use HFOV, paying attention to the tidal volume, well, to the stroke volume and so on. But I don't think that this is very much important, because when you get there, the game is already lost. Yeah. It's not the ventilation there that is going to be very much helpful. You can ventilate them in HFO, you can ventilate them in volume guaranteeing conventional. This is absolutely fine, I think.
Yeah, hi, Dr. Daniel. Just another question. We see a lot of babies who have got chronic lung disease or BPD, and a lot of time we see PI changes with them with hyperinflation lungs. What would the best modality like ventilation strategy in these ones?
Best modality is to avoid this situation. Nothing more than this morning, I received some chest film from somebody from Italy with a baby like that was on the ventilator for 4 weeks, and that to me had already the criteria to be extubated like 20 or 25 days ago. So that's the real point. You don't have to get there, because once you get there and you have such a hyperinflation and you have a pulmonary interstitial emphysema, then the situation is very bad. You can try whatever you want, but there is no magic bullet. There are some of them that are going a little bit better with HFOV. Somebody use even the jet ventilation, but you don't have to get there. To be clear, even if rarely some of our babies can get intubated, we have 0 PIE. We don't have pulmonary emphysema, and it's just because we are extremely aggressive not to intubate them. The most important part is really the non-invasive ventilatory policy, not to get there.
Great. Yeah, I think I agree with that. Any other questions from any other panelists?
Daniel?
Yes, please.
Can you share that your cookbook with us sometime later this week? Your procedures to prevent this is very
is exactly what I brought in the slides. You are more than happy, you're more than free to download the slides. I think I sent it to you, but I can send it to you in PDF as well, so you can use all the doses and the protocol for non-invasive ventilation. There's no problem.
Thank you very much. I think.
My pleasure.
Thank you. Any questions you can take?
There's another question there I see in the chat. Can you call it BPD if a preterm develops oxygen requirement and non-invasive ventilation X-ray changes? Can BPD at 4-5 weeks of birth with no history of pneumonitis requirement at birth? So that's interesting. So technically speaking, and Eduardo is much more versed than me in that, you give the diagnosis of BPD at 36 weeks, not before. But we know that BPD is an evolving process, right? So this is why the concept of chronic pulmonary insufficiency prematurity has been introduced. So clearly, if you have a baby at 4 or 5 weeks with increasing ventilatory requirements, chest imaging is not so good, this is not technically speaking BPD, but surely is evolving BPD. Surely is CPAP. So we have to take care of that, although it still does not qualify yet for BPD.